Hi, welcome to the Addiction Recovery Place, the podcast champion addiction treatment specialists around the world. I'm very pleased to introduce today's guest, Dr. Alicia Leslie, the president of Central Kentucky Addiction Treatment based in Danville, Kentucky. Dr. Alicia Leslie is a physician and president of Central Kentucky Addiction Treatment. Her 27 years as an emergency room physician exposed her to the growing epidemic of opioid addiction, along with the lack of treatment resources. So she felt the need to join a practice where patients are treated by a caring physician with professionalism. Dr. Alicia started addiction treatment and management in 2014. She became board certified in addiction medicine in 2019 by the American Board of Preventive Medicine. In July 2022, she bought the practice where she worked for 10 years in order to expand treatment services for patients. And she also has a special interest in pregnancy opioid management. Dr. Leslie, we're truly grateful for your presence and insights, and we look forward to hearing about your service today. Thank you very much indeed for joining us.
Thank you so much for having me today.
No, we really appreciate it. Before we start, Dr. Leslie, there's a wonderful quote on your website that I would love to read. And it reads,
Okay.
"When you help that one person, you're not just helping them, you help everyone whose lives they touch." This pretty much sums up working in addiction services perfectly. And I just wanted to add that because this is what this podcast is all about. It's championing the great work that you all do. So I just wanted to add that. So no, thank you for that.
No, yes, you're so welcome. I think that's really important
Mhm.
for people to understand that, changing one life, it's a lot more than just changing one life because someone becomes sober, right? It affects the lives of all of those who touch that one person.
Yes, absolutely. Absolutely. So we're just going to jump straight in. Tell us about your journey and how you started Central Kentucky Addiction Treatment.
Well, I also had my own experience with a loved one who was an addict. And I think that, you know, while I was a physician, you think you learn a lot in medicine, and then you're faced with, a medical crisis within your own family. And, I had a loved one who was an addict.
Mm.
He struggled with addiction for years, and I was always there every single day, fighting to save him, fighting for him. And, it was basically almost like living in hell for me because it was painful watching someone destroy their life and feel like I wasn't able to stop it.
Mm.
Unfortunately, he was addicted to both cocaine and Vicodin. Um, and despite my efforts, he ended up overdosing and died. And I carried a lot of guilt as a doctor and felt like, I couldn't save him.
Mm.
And I think that his death was sort of the catalyst that helped me shift my career from being just in emergency medicine to addiction medicine. I wanted to be in a position where I could really help others. There was a realization too that I was an enabler.
Mm.
As I learned a lot more about addiction over the years, I realized I also, didn't do things um, the way I probably should have. And I'm not saying that I am at fault for what happened, but I do think that I probably could have done things better.
Mm.
And that pushed me to learn and to get better and to do better. And I ended up, meeting these physicians that were starting this clinic and about 12 years
Mhm.
ago, and they had started the clinic. And then I joined them 10 years ago and spent a lot of time really learning. One of the psychiatrists that was in the office was my mentor. I learned a lot from him, about the psychiatric aspects of addiction and the management, and then went on to just do my own self-study program and was able to grandfather in to the American Board of Preventive Medicine pathway program and became board certified in 2019. And then that of course moved into me, eventually buying the practice, which I have now.
Mhm. Well, firstly, congratulations. I mean, for you know going so far after something so tragic in your own life, and then progressing to help others with addiction. I mean, that's hugely admirable, and I think that's an amazing story to where you're at now, and obviously with offering the services that you do to your community in Kentucky, that's testament to the great work that you do. And no, that's a pretty amazing story to hear. So thank you for
I
explaining
think it
that.
helps
Mhm.
people. Well, you're welcome. And I think it helps people understand that, I have especially family members, because I have experienced what they're going through.
Mhm,
I know what it's like to be fighting for someone and wanting them to have success. And so it becomes very personal for
mhm,
me because I have experienced it and I do understand, I think on a different level than a lot of other, people in the medical profession that maybe don't have direct experience as I do.
mhm. Absolutely, absolutely, and I suppose that obviously, you said it transfers to your own personal experience. You can then relay that to your patients as well, and that puts a whole different slant on treatment, I think, and that's a wonderful story. It really is. Dr. Alicia, what is an addiction to opioids, and how does this affect someone's physical and mental health as well as their lives with their family and the community?
Well, opioids are, narcotic pain
Yeah.
medications,
Yep.
right? And we know them more familiarly as morphine, codeine, hydrocodone,
Yep.
oxycodone, and then
Mm.
heroin and fentanyl. And, addiction is a chronic brain disease that is characterized by both physical and psychological
Yep.
dependence. And what you see in addiction is that we see the use of drugs despite the harmful consequences, right? And we see people who actually lose control over their using. And that's unfortunately coupled with the development of tolerance over
Yeah.
time. And so we see increasing use of the drug. And then what happens to patients over time as they continue to use is they start to develop problems with focus, memory, the ability to
Yeah.
learn. They start having changes in their decision making abilities. We start to see poor judgment. And all of these changes will eventually lead to really, negative
Yeah.
consequences, the loss of their jobs. We see people lose their cars, their homes. They destroy relationships with their spouses, their parents, their siblings. I mean, and of course, we see a lot of people who eventually, lose their children or lose custody of their children, all because of addiction. And so what you see is that addiction really kind of impacts every aspect of someone's life, not just, the financial.
Mhm.
And so the beautiful part of addiction is that you can really help someone turn all of that around if you do it in the right way. I mean, I have a patient who was actually homeless. He used to sleep in, empty post offices at night. And now, he's been my patient, 7 years later, he's sober, he has a really good job. He manages about 50 people underneath him at his job. He's owns his own home. He has, several cars. He has all of his children. He's married. I mean, he has a wonderful life. So, you can take someone who's had all of the negative consequences from drug use and you can help them turn their life
Mhm.
around. When you talk about addiction, you also have to talk about, the impact on the community, right?
Absolutely.
So it affects crime rates,
Mhm.
hospitalizations, child abuse and neglect
Mm.
cases, and obviously, the communicable diseases like HIV and hepatitis C that's in the communities. So when you look at, opioid addiction, it's going to affect sort of every aspect of not just, someone's individual or personal life, but it does affect the entire community as a whole.
Yes, indeed. I mean, it's something that can happen so quickly as well, and without many warning signs, to be honest, sometimes. And it's always lovely to hear real success stories from professionals that have very dedicated to their work. And you've the chap that you were just talking about, who you worked with for 7 years. I mean, that's if you had told him 7 years ago what he's now doing 7 years later, he probably wouldn't have believed you. Which is, yeah.
No. And his brother's actually my patient as
Mhm.
well, and they were both sleeping in post offices together, and they're now both, sober and living very productive
Yeah.
lives. And he says to me on a regular basis, as a lot of my patients have, "You saved my life." And I always say, "No, I didn't save your life. You saved your life, right? You came to me for treatment. I just helped you." And it's a beautiful thing because this is where the whole idea that you brought up in the beginning, which is, when you change the life of one person, you change everyone around them. If you look at him, I mean, you look at all of his family, his friends, everyone who has touched his life has now been affected by this positive
Hmm.
change. And that for me is the most rewarding part
Hmm.
of treating addiction.
Hmm. Definitely, definitely. It always gives you a nice warm glow when you know that your work is doing something positive. Where my own experience of working with people in addiction, it could be such a negative environment. So you've got to take the positives and kind of push those positives. Say, this is possible for you to do this. That's my own personal view when I was working with people in London. Thank you for explaining. That's a perfect description of opioid addiction. That really is. That's wonderful. Your your program provides a vital service of people experiencing addiction in Kentucky. Can you describe in some detail what you offer and how the program works in terms of your service delivery?
Yeah. So, we're a really, really small
Mhm.
practice. I only have about 200 patients. But the reason for that is that I really individualize to the patient what their specific addiction is and tailor the program around what their specific needs are. You know, some people like to say it's a type of boutique type of
Mhm.
practice because they only see me when they come to the office. I am their physician and I am the only person that they actually see. And the office is kind of set up, what we call a DPC model, which is a direct primary care model, where, patients do pay a cash fee to see me. They don't put it on their insurance. We do this for privacy reasons. A lot of patients don't want there to be any type of, implication or on their insurances. So we do it all kind of as a private model. And this is also to ensure, patients'
Mm.
privacy since addiction can be such a sensitive topic. We've developed the clinic to encourage people to work and to keep working. And so I've adjusted the clinic. When I took over, I adjusted the hours so that we have evening hours for people who work swing shifts. We have weekends. We do one Saturday a month so that people who have Monday through Friday jobs can come on a Saturday. That's why we also have evening hours. And then we have regular office hours, and we do this so that patients don't use their PTO time or vacation days and can be able to work without, any interruption.
Mhm.
Because I feel like being able to work and provide helps build confidence, self-esteem, and we're helping them rebuild their lives. And so our office accommodating that is extremely
Mhm.
important to
Mhm.
me in that, we're providing a service, but we're also doing it very, very in a very personal way.
Mhm. That's so basically you're working around your clients.
I actually
I
do.
love that.
Yes, I work around their
Mhm.
schedules.
That's quite a unique opportunity for people to kind of enter that kind of treatment. So that's how many Saturdays? It's one Saturday a month that you work, that you have your office open
Y
for people in full-time work. So you're
Yes, I absolutely it's 1 Saturday a
Mhm.
month, but again, we will accommodate what they need. So if they're traveling for work or they're sick, I'll do a telehealth
Yeah.
visit so that, again, they don't miss work. Because for me, that's extremely important. And I don't want them using, their vacation days to go to the doctor. I don't feel like that's conducive to long-term treatment,
Mhm.
right? We want to set up a program that patients are able to do over the long
Yeah.
term, not just, temporary because it starts to feel difficult.
Yes, definitely. That's pretty unique opportunity, and I think that's absolutely wonderful that you're able to offer this. So thank you for explaining that. What are your views on harm reduction, and how does this play a pivotal part in addiction treatment? Because harm reduction globally has got quite different variants. I mean, it's very different here to what it is in Europe and the UK, or I'm kind of learning myself. So I'd love to hear your explanation around your views on harm reduction.
Well, obviously, everyone wants harm reduction, right? And basically, the whole goal of harm reduction is to save lives and then protect the health of those who use drugs.
Hmm.
Um, there are obviously a lot of programs, needle exchange programs and providing, Narcan, the reversal drug that people can use. during, if someone is overdosing. And so those are types of harm reduction programs. Um, but I feel like, one of the biggest harm reduction, tactics that we can use is treatment. And the biggest obstacle that I find for that is sort of this misperception and misunderstanding of
Yep.
MAT, medication assisted treatment, which is extremely important. So I will commonly hear people who are not very educated in the world of addiction say things like, oh, well, you're just replacing one drug with another.
Mm.
And this couldn't be further from the truth. We know that MAT or medication assisted treatment has been proven to decrease opioid related overdoses and
Mhm.
deaths. There was one study that found that those who were not receiving any type of MAT were actually 8 times more likely to die of an overdose than those who were in treatment, right? So you look at harm reduction can be in a lot of different forms. In my particular office, we focus on MAT. And for people to understand, what Suboxone is, it's a combination drug of buprenorphine, and
Mhm.
naloxone. And Suboxone it can decrease pain, and it decreases pain perception, and it does a lot of things in the brain. It increases the reward related behavior in the brain while reducing someone's cravings to use drugs. So there's neurobiological evidence that the levels of the dopamine in the brain, which are typically low in a lot of addicts, and that could be from a lot of reasons, from the start of using drugs at a really young age so that the frontal cortex of the brain doesn't develop as well. It can also be partially genetic. So what we see when we start using drugs like Suboxone is that patients actually, for the first time, will say, I feel normal.
Mm.
They're not getting a
Yep.
high. They're actually raising those dopamine levels to normal places in the brain. So they actually start to feel normal and they're able to now
Mhm.
function. So it's hard for me to, when I hear people say, oh, you're just replacing one drug with another, that's frustrating to
Mm.
me because if you look at insulin, oh, well, then why, they need to get off the medication as soon as possible. And there's all these mental, or misperceptions in the community. And I'll give you an
Mm.
example. This is what I always tell my patients because they come to me and they're like, well, I really need to get off this drug by a certain time. And I say, look, depending on your genetics, the age of use of you started using, you may or may not be able to come off the medication. And there's a lot of factors that go into that. So, one of the things or examples that I use with patients is insulin,
Mm.
right? So, people are diabetic because their pancreas doesn't make enough insulin. We give them insulin, right? And we get their blood sugars level and then they function.
Mhm.
We don't give them insulin for, let's say, 3 years and then take the insulin away and expect the pancreas to be able to make insulin. It doesn't work that way. The brain is the same way. We can't just give a drug like
Mm.
Suboxone for 2 or 3 years and then just take the drug away and expect the brain to produce the appropriate levels of dopamine, especially if they have a long history of addiction or they started using drugs when they were 13, 14, 15, because those dopamine levels may never ever be within normal because that frontal cortex, that reward pathway of the brain never developed properly,
Mhm.
right? So if they are using that medication or they're on that medication and they feel normal, it's like the brain insulin. You know, I always say, why in 3 years would I just take that away from you and then expect you to function normally in society?
Mhm.
Now, I'm not saying that patients can't do that. This is why, while they're on medication and they're in an MAT program like what I
Mm.
have, we spend a lot of time on the psychological,
Mhm.
right? Because the brain, the medication's helping with the physical dependence. Now we spend a lot of time focusing on the psychological
Yep.
dependence. That being, do they have PTSD? Do they have trauma related issues that we need to work through? Do they have depression? Do they have anxiety? We address all of these things,
Mm.
right? And then over time, we create an environment where the patient feels comfortable. Now, if they want to then taper and try to come off the medication, of course, we support that.
Mm.
But I think when you look at treatment, if you look at studies and you look at it, which is in contrast, just straight detoxification programs, abstinence based programs, and those that are just psychosocial therapies alone, they have consistently failed in comparison per the medical
Mhm.
literature.
Mhm.
right? So I feel like it's extremely important that we educate families, friends, law
Yes,
enforcement, even those in the medical community, and most importantly, the policymakers, those in DC who make decisions, because eventually changing these misconceptions will actually lead to better access for
mm,
treatment for everyone.
absolutely, absolutely. Suboxone was a real game changer for treatment, especially in the UK. It's a very different medication to, say, the old school methadone, and there's a lot more success stories around Suboxone that I've experienced. So you just explained it perfectly as to why this works,
Right.
and it's probably the most successful out of all of the medication on offer that people can have. My own view on methadone, it's a little bit old school, and Suboxone for me was, I saw the changes in my clients when I work with them as well, and I realized that it's a very different style of therapy. So no, that's wonderful. You've actually answered my next question as well, so thank you very much for that.
Well, I do want to say because I
Please.
think in the next question
Mhm.
we were going to talk a little bit about why it's
Mhm.
important. Let
Yeah,
me also
please,
say
please
this
do.
now. Our program is MAT
Mhm.
based, and we don't use methadone in
O
our clinic, although it is offered other places in the community. We do offer Vivitrol though, which is an
okay.
injection, and now of course there is Sublocade, which is the brand name version of the Suboxone
Mm,
injection, and there's a new one out, I think it's called Brixadi, which is also another injectable type of
mm,
buprenorphine, so that patients who are not comfortable necessarily taking, the sublingual tablets or strips can get a once a month shot. My patients that do that actually love it. They say that they feel free. But again, yeah, I feel like it's not just using MAT, it's MAT with a lot of
mm,
therapy and counseling so that the patients feel
mhm.
supported. And it's about rebuilding self esteem and confidence in people so that they can rebuild their lives in a way where they don't want to use.
Most definitely, because the therapeutic side of it has to come along with the medication side of it as well. I think counseling and therapy is a vital component for someone to help with their addiction. So, since you started your practice and career in this sector, what changes have you noticed in drug use and the additional risks that this is posing to communities around the country, really?
Yeah, I think if we look at
Yeah.
addiction, right? I believe that addiction, especially in the United States, has kind of been in three phases. And I've witnessed all three phases, right? The first phase was this whole pushing of narcotic pain medication by the pharmaceutical
Mm,
industry. And at the same time, there was this big shift in hospital policies to get physicians to control patients' pain. And this led to what I call the prescription opioid addiction phase. We know a lot about this phase. There's movies out there, Painkiller, the movie Dope Sick. It kind of represents that phase
mm,
of addiction in the United States. So that was the first phase where we see all this
mm,
prescription opiate addiction. And then people became more aware of it, and they started implementing these state monitoring programs. In Kentucky, it's called Casper, which is a program that monitors how many opioid prescriptions patients are getting. And those started appearing all over the United States. And physicians, as they became more aware, they started prescribing less and less and less. It became much more difficult to get pain medications. And then there was a spike in heroin use. And that's what I call the second phase, was the heroin phase. So everyone now, because it's a lot cheaper and it's a lot easier to access, they start moving now into this heroin phase that we saw. And so there was this drastic increase in heroin use and heroin overdoses.
mm,
A lot more, IV drug use at that time. And now we've moved into what I call the third phase. And this is now what we call the synthetic opioids. This is the phase now where we started seeing this shift into fentanyl, and other synthetic opioids on the street. And that's the phase I feel like that we're in now, right? And that is
mm,
dangerous because what we see now is there's so much fentanyl coming in from
mm,
international, destinations. I mean, most commonly, we hear stories about it coming from China. And this isn't, regulated fentanyl being made in a pharmaceutical, a regulated pharmaceutical, factory. This is coming from kitchen labs where it's not regulated. There's no idea of the potency of what's being shipped over here. It's being shipped over here in massive amounts. And then we're seeing it change forms. It's not just cutting of street heroin. We are seeing now garage pressed pills where people can actually take fentanyl and they can press pills to look like oxycodone or hydrocodones or, Norco,
Mm.
the three, even
Yeah.
Valium, and they garage press them and they make them look like real pills and then they sell them on the street. So now people, you're now really in a dangerous zone because we have people that think they're buying
Mm.
pills that aren't buying pills, and then the pills aren't what they think they
Yeah.
are. I can tell you that in Kentucky, which was really, really high area with Eastern Kentucky and the Appalachia and opioid addiction, we used to see so many
Mm.
pills, and we still do. The problem is that patients will tell me, "Okay, yes, I took an oxycodone." Well, then I expect to see that on the drug screen. That's not what I see. I actually see fentanyl. I realized at that moment
Mm.
what they thought they
Mm.
took versus what they actually took was very
Mhm.
different. And unfortunately, we see this time and time again at the hospital. I haven't even had a real heroin on a drug screen in probably 3 years. It's all
Gosh.
fentanyl. For me, that is extremely dangerous for people who are buying drugs off the street. And this is why we've seen this drastic increase. So, in each phase, the number of overdoses and overdose related deaths is increasing over
Mm.
time, despite the fact that we're making treatment more available. And that's because of the unpredictability of fentanyl and the amount that's on the streets.
So you let me just get this right. You said that you've not had a positive heroin on your on a drug strip for 3 years?
It's been about 3 years. Even when patients tell me, "Oh, I did
Yeah.
heroin, I'm
Yeah.
sorry," or at the hospital when have resuscitated an overdose and they say, "I shot up heroin," and then I get the drug screen and it's not
Mhm.
heroin. It's almost always 100% fentanyl, at least in
Yeah.
Kentucky. Now, I can't speak for other parts of the
Mm.
country, but what we're seeing here is I'm not seeing heroin. It's all fentanyl. And we see other mixed overdoses. I mean, obviously, we'll see meth, and I see an occasional cocaine. We'll see oxycodone, hydrocodones, some of the morphine derivatives, things like
Mm.
that. But actual
Mm.
heroin, I haven't had a positive heroin on any of my drug screens for my patients in 3 years.
So how that must be quite a thing to go back to your patients and explain to them, and that must be a real reality check for them as well to think, "My goodness me, you know, I've thought I was taking heroin, I'm taking probably one of the most destructive drugs, that can, it can kill me basically very quickly." That must I mean, that must
Absolutely.
be a real reality check for them. What's their response when you tell them, "This is your test result," you know?
Well, obviously, there's a lot of disbelief, right?
Mhm.
Because there's no honor in in drug
Oh,
dealers,
no.
and a lot of times I don't think that they
Mm.
know what they have either,
Mm.
because things are just passed so much on the street. I kind of say it's like the Wild West. You don't really know what you're getting. You don't know where things are coming from. Most patients are very surprised. Are they do realize that the awareness of the severity of fentanyl is out
Mm.
there, and patients do
Mm.
know. But again,
Mm.
addiction will get in the way sometimes of their decision making and, of course, their continued use. But they do become more aware. And, I'll talk to them about it and I'll say, look, there was no heroin, it was all fentanyl. And they do all seem very surprised. None of them say, oh, well, I expected that. They are all
Yeah.
genuinely
Mhm.
surprised. I've even had patients say that they took a Valium,
Mm.
what they thought was a street pressed Valium or was a Valium, and it turned out was street pressed fentanyl. And, Prince, let's look at what happened to Prince. Everyone knows who Prince is. Everyone knows that Prince died of an
Mm.
overdose. When they did his autopsy, what may not be complete public knowledge, but what we know is that he thought he was taking Norco, which is a hydrocodone acetaminophen combination drug.
Mm.
It turns out that on his autopsy, it was fentanyl, which we know more than likely came from the streets and was garage pressed somewhere.
Okay.
So even Prince
Mm.
was a
Mhm.
victim of
Mm.
street
Yeah.
fentanyl.
It just shows how this can get anyone really, doesn't it? So do you see the
Absolutely.
fentanyl epidemic to be one of the biggest threats in the communities when 20 years ago, the main drugs of choice were heroin and crack? Because it's kind of really ramped up, as you said. It's kind of like a massive epidemic now with high risk.
It's absolutely, it's massive, and what's happening is it's all coming into the country, it's extremely cheap, it's not regulated, and it's
Mm,
everywhere. I mean, it is everywhere. Like I said, when people are buying pills off the
mm,
street, they think they're getting something that came from, you know, a pharmacy somewhere, but most of the time it's not. Unless you actually, and I even tell my patients, unless you pick up the prescription yourself from a pharmacy, there is no guarantee whatsoever that what you
mm,
have or what you think you are taking is actual
mm,
hydrocodone or
mhm,
oxycodone. It is more than likely, if you have bought it off the street, it's going to be fentanyl or have some fentanyl in
mm.
it. It is absolutely rampant.
That's a very important message to get out to people, isn't it? Really, that what you're buying on the streets really isn't what you're experiencing. It's very different to propaganda. This is like the real deal. What's going on in this country? We're seeing it in Europe now as well with fentanyl and these other drugs that are coming in. It is quite scary, really. When I was in the UK, we had a scare with anthrax, heroin laced with anthrax, and we had overdoses left, right, and centre. It was quite a time to be working in the sector, and fentanyl is just another thing that's just ramping all this up, and it's truly tragic. I mean, what have you found to be some of the challenges of working with people suffering from addiction, and how have you overcome some of these hurdles, Dr. Leslie?
You know, I think one of the biggest challenges we have is that a lot of people think that when they go into treatment or they ask for help, that it's a personal failure. And I spend a lot of time trying to help people change their perception of what treatment really is and help their families understand what treatment is and that it's a long process. It's not an overnight fix. I think it's imperative that we destigmatize the idea of getting treatment. It is a brain
Yes.
disease. It is not just something people can willfully just, okay, well, you just need to quit using drugs. That really frustrates me when someone says that, when there's so many more, complicating factors that go into it. It is a chronic brain disease that we need to treat as such. I feel like the idea that it's just something people can will themselves to do is probably, to me, one of the biggest challenges that I have when it comes to getting people to accept
Yeah.
treatment. And this is again why I've really sort of tried to develop a really personalized program so that I can kind of get to know my patients in a way to understand what in their mind has been the obstacle to getting help before
Mm,
and what can we do to change that so that they can start to value their treatment and what it's giving them and change their perception
mhm,
of themselves sober as well as understanding what addiction did. Addiction isn't who they are, it's what their past was, but that's how all of these things come into play and how you move forward. But I feel like the biggest challenge that we have is that people view treatment as kind of a negative thing because they feel like, well, if you have to ask for help, then that in and of itself is another failure when it's really the
mm,
opposite, right? The person that can ask for help is doing the right thing. They're actually going to set themselves up for a lot more
mhm.
success.
And you said a word earlier, stigma. I think that's
Hmm.
unfortunately, that's one of the biggest hurdles around family and friends, and I think stigma has to be removed from drug addiction. I think that's a very important thing.
If you look at addicts,
Mm,
right? People have this idea when they say what an addict is, and people's minds go to this place of like some kind of scraggly looking character in the back of an
yeah,
alley, shooting up because movies have given us this sort of negative perception. What I see in my office is I see moms, I
mm,
see
yeah,
professionals, I see college
yeah,
students. I mean, it is everywhere.
mm,
And every person that you see in some shape or form could be an addict. It is not this sort of this picture that people have developed in their mind of what an addict looks
mhm,
like. It's not people who they perceive as the dredges of society. It is people who are very successful. It is students, it is your brother, your sister, your friends, your your college buddies, your coworkers, even your bosses. I mean, I can't tell you how many high-level
Mm.
professionals that I have, uh, that I treat.
Yes.
It's everywhere, and the idea of this of treatment being negative is just for me, it's the biggest challenge that we have. It's how do we change perception of the community to believe that treatment is a good thing?
It's probably one of the most positive things anyone can do who is addicted to something is to enter the to walk through that door and ask for help. That's probably one of the
Absolutely.
hardest challenges because they know how tough it's gonna be to address their many, many problems. It's not about the drug use, it's the whole kind of, their whole lives basically. So your service in Kentucky doesn't only help those experience addictions to opioids. What are the other addictions that you help with?
Well, I'm board
Yep.
certified in addiction medicine, so we can really address any type of addiction. Obviously, we see people who suffer from alcoholism, but then we also treat people with, sex addiction, gambling addiction, internet
Mm.
addiction, gaming.
Yeah.
So we treat all types of addictions, but I personally have a soft spot for people who have an opioid
Sure.
addiction and they're
Mm.
pregnant. That's kind of where I've become a little bit more of an expert in our area as well is treating those and managing patients who are
Mm.
pregnant with their opioid addiction and coordinating their care with their obstetricians and coordinating the continued medications while pregnant and during and after delivery.
That must be incredibly rewarding work to do. You're not only helping the mother, but you're helping the baby, you're helping the father, you're helping grandparents, and it's a very specialist area to help pregnant women through addiction. So, I certainly take my hat off to you. That's wonderful to hear. At your practice, do you promote peer support, and how do you ensure that your clients receive the best support to overcome an addiction, even after completing the program? Or, as you said, people are on this for life, but some people move on. I mean, how do you ensure that people can come back to you if they do relapse?
Well, absolutely. So we don't have a set number of days to complete a program. I individualize the treatment to the patient's needs. Um, and I do think that many of my patients will be in treatment
Mhm.
indefinitely. Um, in terms of like the peer support programs, such as like AA and NA, we used to offer those, in my office. And then when COVID came, we kind of stopped providing those meetings. The feedback that I got from my patients is that they loved not having to go to meetings. Some of them chose to continue meetings outside, but the majority of my patients actually preferred not to participate in meetings. And some actually even reported that for them, it was
Mm.
counterproductive to always hear people talking about addiction and the things that they did over and over and over and recounting stories. And for them, that sort of were triggers. So we modified the program, and I've always focused on just individual one-on-one type of therapy, focusing on whatever their, PTSD, their anxiety, their agoraphobias. I have a couple patients with that, their OCD
Mm.
behaviors, all of the things that they have that sort of impact their sober life is what we tend to more focus
Mhm.
on. And I encourage them to do meetings if that's what they're comfortable with. I don't require it. And as far as completing a program. For me, sobriety is a journey, it is an ongoing process. If they decide that they don't need the medication anymore or don't need to see me, we help them transition out. But they are always 100% welcome to come back anytime. Will always take a patient that I've had before back. And actually, I'll take any patient that comes to my
Mm.
office and wants help. And I give my patients access to me. I mean, most of them have my personal cell
Mhm.
phone. They'll actually text me or they'll call me if they need me for any reason. We answer the phone after hours to in a
Of
reasonable
course.
uh,
Mm.
space. But patients that are in my alcohol outpatient treatment programs, they do get 24-hour access to me just because sometimes people feel like drinking late at night. And I've noticed that sometimes if they need me in that moment, they can always give me a call and I'll always answer the phone to try to provide them with that immediate support.
My goodness me, that's incredible. That's wonderful to hear. So how does someone in your community enter your program, and what is the process for this? How does, what what
It's
someone
it's a
do?
very simple process. They can call our office. Yeah, our office phone number is 859-238-0018, and they can make an appointment. We do a lot of our preliminary forms and sort of intake screening things digitally. We send it through the computer, and they can answer some questionnaires before they come. And then they make an
Yep.
appointment, and I will see them in person. They will come and sit with me, and we'll do a full intake, and we'll go through every part of their history, and then eventually I will get to know them, and I'll develop a program. I will share with them what I think the ideal program is for them and for their success, and then we move forward. So anyone can come to
Mhm.
my office and be my patient.
Wonderful. Thank you for explaining that to us. So where can people
Yeah.
find you and your work online?
Our We have a
Yep.
website. It's www.kyaddictiontreatment.org. So that's KY is for Kentucky, addictiontreatment.org.
Fabulous. And lastly, is there anything I should have asked or that you'd like our audience to know about?
The only thing that I'd like to say is that if you are out there and you're struggling with addiction and you're thinking about getting help, let me just say this. Every person that has 10 years of sobriety, 5 years of sobriety had a first day. Everyone. So you can let that day be today. It is never too late.
Well, I couldn't have thought of a perfect end to end this podcast. Dr. Alicia Leslie, thank you so much for joining me today. And we look forward to
You're
hearing
so
about more
welcome.
of your work in the future. Thanks so much.
Absolutely. Thank you so
Thank
much.
you.